Good afternoon. My name is Scott Anderson, President and CEO of Zions Bank, and it's my honor to welcome all of you to our Zions Community Speaker Series today, where we will be discussing Your Health is Your Wealth, solving for healthcare and the economic inclusion equation. Your health is your wealth has become a phrase that rings true now more than ever as we continue to recover from the COVID-19 pandemic. Today's Community Speaker Series will examine the health and economic disparities that exist in communities across our footprint, while exploring the correlation between health and economic well-being. Today's conversation will feature Mikelle Moore, Chief Community Health Officer at Intermountain Healthcare, Jake Fitisemanu, Chair of the Utah Pacific Islander Health Coalition, Dr. Richard Ferguson, Chief Medical Officer of Health Choice Utah and founder of the Black Physicians of Utah, Dr. Jose Rodriguez, Associate Vice President of Health, Equity, Diversity, and Inclusion at the University of Utah, and Dr. Sheila Giffen, Executive Medical Director at St. Al's Health System. We are so fortunate to have the opportunity to learn from such dedicated community leaders in healthcare, whose work has significantly improved, transformed, and in some cases saved the lives of the most vulnerable populations in the communities we serve. I want to thank our One Zions team, who's responsible for organizing and producing today's event. And thanks to all of you who have chosen to zoom in on our Community Speaker Series today. We all appreciate the valuable contributions you make to build an informed society where we can all continue to learn, live, and thrive. Building a culture of inclusion begins with us. It begins with me, and it begins with you. So with no further ado, I'd like to turn the time over to Sulaine Pinoki, our Senior Vice President of Diversity, Equity, and Inclusion. She will introduce our guest and be the moderator of today's conversation. Sulaine.
Thank you, Scott, for that warm welcome. And as Scott stated, we are truly honored to hear from such dedicated community health leaders in today's Community Speaker Series, Your Health is Your Wealth, solving for healthcare in the economic inclusion equation. With no further ado, I would like to introduce our community speakers and dive right into the conversation. So please join me in welcoming Mikelle Moore, Chief Community Health Officer for Intermountain Healthcare, Jake Fitisemanu, Chair of the Utah Pacific Islander Health Coalition, Dr. Richard Ferguson, Chief Medical Officer for Health Choice Utah and founder of Black Physicians of Utah, Dr. Jose Rodriguez, Associate Vice President for Health, Equity, Diversity, and Inclusion at the University of Utah, and Dr. Sheila Giffen, Executive Medical Director at St. Alphonsus Health System in Idaho. So to everyone listening, I'm just thrilled to hear there's so many diverse pathways, right? Different pathways to pursuing a career in healthcare. Wanted to also share some resources for data and research on healthcare disparities, health disparities and opportunities that lie across our footprint. The Kem Gardner Policy Institute's Diversity in Utah data book here in Utah breaks down the economic indicators of education, employment, housing, and healthcare by race and gender. So we encourage you in the state of Utah to utilize that research in your efforts. And in Idaho, you can look at the County Health Rankings National Findings Report that will break down the disparities in a similar way. And what we've learned from the data is that communities of color and lower income households were hit much harder by the pandemic than any other demographics. And I'm thrilled to see how passionate and committed all of you are, you and your organizations, to serving the most vulnerable populations in our communities. Now, I wanted to integrate the power of storytelling in today's conversation. So I've asked each of our guests to think of at least one story, personal or a story of a member in our community, that illustrates the intersection of health and economic well-being. We've seen so many families face economic devastation due to unexpected health crises. And going back to the theme of today's conversation, your health is your wealth, in what ways has this rung true to you and the communities that you serve. So let's go ahead and start with Jake.
That's a really great question. And the first thing that comes to mind is really the nuances that we have around defining those words health and wealth. In our Pacific Islander community, we've done several needs assessments in recent years that have been rigorous in terms of their academic or research methodologies and all that good stuff. But when you're sitting in focus groups and doing interviews and surveys with people and talking about health, we end up spending the first 20 minutes of that conversation defining what health is, because the words are so different, and the words we have to create words in Samoan and Tongan, etc., that reflect what we're meaning when we're talking about Western clinical health or those type of guidelines. And so it's interesting that we frequently hear that in our worldview or our ancestral cultural worldview, that health may not have anything to do with eating healthy or with physical activity or with your actual ability to function in life. What health really boils down to is balance, is good relationships with the people around you, is the ability and the willingness to serve in your community, in your church, to teach your grandkids the culture and the language. Those were things that resonate with people when we talk about health, rather than, you know, how many servings of vegetables do you get a day, or do you get 30 minutes of rigorous physical activity every day. And the same with wealth. And so the story that I share very briefly is from a gentleman, an elder in our community, who really made changes, who initially put his own physical health on the back burner, and realized that by preventing and going through programs and other measures that can help increase his health, he's able to stick around longer. He's able to serve in his church more actively. He's able to be around and teach his family and his grandkids and be there. And that was a lesson to many people around him who he was able to influence, because he is an elder in the community. And by being able to leverage and being able to teach and work with folks to understand what we mean by health from a healthcare system perspective, and being able to acknowledge that they have wealth in that knowledge and that experience and that presence that they have in the community, that is wealth that they have to pass on as well. And that was a really cool experience for me to be able to see personally.
Thank you so much, Jake. I love that theme around balance, defining health around those terms. And the elders in our community, especially Pacific Islander community, play an integral role in our community health. And so love that example that you shared. Dr. Giffen.
Sure, there are so many stories we could tell, aren't there? I mean, too many to choose from. And I think I have two things. In working with employees, doing employee health programs as part of my trajectory to where I am today, we really do see, in terms of the healthier we are, the more we're able to show up at work and to be employed. So there is a direct correlation between those two things. And then when we talk about some inequities that occur, there are many across the board that we could all speak to. One of the stories that I think of the most is when I was working with this really bright young man, and he had come from a different country and was working on a frontline community worker. And when I found out he actually had a PhD in his home country and was working in a position with minimum wage, essentially, and was struggling to meet the needs of his family, and then having to decide, had a diagnosis of new onset diabetes, and that's a very expensive disease to have. And so was making decisions for his family members, and shortcutting his own health so that he could care for the rest of his family. And that even included family members who do not live in the United States, because he was sending back funds to help the rest of his family. So I think that's one case of many, but here was someone highly educated and struggling to make ends meet and take care of his own health conditions. And definitely there was a real imbalance and equity for his health care and the rest of his family. So.
Thank you for sharing that. It's far too often we hear those stories of the self-sacrifice and sacrifices that are made to support our families here. Dr. Rodriguez.
So when I think of our theme, health is wealth, the themes of education come kind of they overcome me, right? Because I am extraordinarily fortunate to come from a long line of highly educated Puerto Rican people. My great grandmother graduated from college, and very few people can say that. So I've been blessed for generations from their sacrifice. But when I think of the wealth that we have, there's the wealth from physical health that actually lets us work. And then there's the wealth from mental health that actually lets us enjoy our work and our lives. So this year marks the 1-year anniversary of my father's passing. And my father was a very intelligent and strong-willed man who lived by his own principles, and he did not believe that COVID vaccination was right for him. He wouldn't get vaccinated. The Delta wave came and it killed him in 24 hours. It was a horrifying death where he suffocated. And I think about what that has done to our family, in the sense that it has stolen mental stability from my mother, and in a lot of ways from us children who can't make sense of his passing. And my mom has suffered greatly and is really going through a prolonged grief reaction, which has had devastating effects on what she wants to do and what she can do. She is slowly recovering, but it's been more than a year. So definitely health is wealth, but having people that are with us and stay with us in a relatively healthy way is also wealth.
Wow. Thank you, Dr. Rodriguez, for sharing that heartbreaking story of your father. May we carry his memory and legacy in our hearts today. And may our love and comfort be with your mother and your siblings as well. There's far too many of us who have lost close loved ones, relatives, friends, community members, faith leaders throughout the pandemic. So may we honor all of their memories in today's conversation as well. Let's jump up to Mikelle.
Thank you so much. You know, when I think about this statement, our health is our wealth, I think about the disparities that exist in the communities that Intermountain Healthcare serves. And you know, there's at least a 10-year life expectancy difference from one zip code to another in the healthiest parts of our service areas. And that disparity is something that makes us really uncomfortable as a health system who has created what we hope is access to care regardless of ability to pay. And yet that health access has not produced, or that access to health care has not produced health. And when we look at what other data points go along with those disparities in longevity, it's differences in income, education, et cetera. And so when we started thinking about how do we serve the whole person, whether we think about the social needs of our patients or the needs of the people working for Intermountain who have the potential for greater wealth earning in their career with Intermountain, we really expected that we'd be working around issues of job access. And so I'll share a story. I mean, we have helped even patients in screening for what are their needs, learning about a wide breadth of needs, including you know, a diabetic patient who was able to work, but he worked in the construction industry, didn't have the type of shoes that he needed that would allow him to be on his feet. as a diabetic and safely work. And we were able to get those shoes and put him back to work. But by far more than that, the needs that we hear about from our community members, our patients, and our own employees are much lower on Maslow's hierarchy of needs. It's need for food and affordable, accessible shelter, a home, that kind of underlays this need for wealth before health is even possible. Having those access to basic needs is a far more important issue facing most people today. And I think about what's happening in inflation and our own experiences going to the grocery store. It's kind of overwhelming to think about how that's affecting someone who is experiencing that life expectancy disparity, that income disparity, education disparity, and really suffering in a way that's much more at the core of our human existence, feeling safe and not going hungry or letting our children go hungry.
Mm-hmm. Oh my gosh, all those challenges that you just outlined can layer upon layer, right? Just adding more of a burden, physically, mentally, and economically, compounded, right? How do we even begin to resolve, or provide relief for some of those challenges, right? Which is why the work that all of you are doing is so important at all levels, right? Of the needs, right? Thank you so much for that, Mikelle. Let's jump to Dr. Ferguson.
Oh, so my example of how I've seen health as well, I guess from my personal experience, just trying to make sure I frame my example correctly. So I look at, it's one of the few things that a person, and often patients that we treat, can try to control. But if you don't give them the means to kind of, so that they can get as much access to care or live their best life, and best life as in, can they be able to meet their potential health needs? Can they be able to go through preventative screening? And so I almost try to look at it almost monetarily sometimes. Like, wealth is not always what's in your pocket. It's often, what can you do the best to make sure that you don't have high blood pressure, you reduce your risk for diabetes or becoming obese. And I also think about the long-term effects of, second to what student debt is healthcare debt, right? I believe, isn't it something like, I want to say it's 190 billion. No, excuse me. I know it's not the trillion mark. I think student debt is, I want to say that's like 1.2 trillion, but healthcare is right underneath that. And one thing that we can try to do as physicians, and particularly as community leaders, physician leaders, is try to show people a path and do more to unite resources together. Because, Intermountain does a lot, University of Utah does a lot, the county does a lot, but often these resources don't all talk to each other. They don't all sit in one place. So I feel that I take it as a personal task and a mission to try to connect. Thank you, Jose. I knew it was like a little bit under 200 billion, but we could reduce people's healthcare expenses if we can just show them a way to live a healthier life. And so that's where I feel that health is wealth, because you could be a multimillionaire, but if you aren't well enough to walk a few feet because you've got claudicative pain in your legs, or you've got anginal pain whenever you walk because your hypertension and your diabetes wasn't well controlled, well, what are you going to do with all that money? So, and if you're able to be healthier, you have more time to gain wealth. You can actually aspire to go to school. You can aspire to change jobs. You can aspire to, one big thing that was a big factor for many in the Black community, why it was difficult for so many to attain or accrue wealth during the pandemic, and many people had to get assistance, is because quite a bit of the Black community in the nation are essential frontline workers. And many of us that are sitting here on this call are probably remote. Probably by a show of hands, most of us have the ability to do so. And so many people suffered because they had to come to me, and this is where I bring up the story of they were symptomatic of COVID. They had to come into the ER to me to get a sick note, but they wanted me to say, all right, I know I have COVID. I know how to protect my family, but can you say I don't? Because I can't miss any more work. And if I miss more work, I will not be able to provide for my family. I won't be able to make the next rent when it's due. I won't be able to make my car note to be able to get to work. That's the difficulty that I had to see and address. And I go, wow, do I write a note where this person is clearly going to put others at risk? Or do I allow them to try to go to work and say, all right, here's a mask, say you have to wear this mask all the time. And it's sad that so many people, particularly people of color, but particularly those in the Black community that I serve, they had to make that often that call. And the thing is, I wish they had an option. Many did not have an option during the pandemic. And even now to say, oh, I'm just going to switch my role and leave my job. And mind you, we as healthcare workers are frontline as well. So let's not be dismissive of that. Our nurses, our PAs, our folks that work taking care of the community in the ER, at clinics, vaccination stations. But there are many that don't have the option to, once again, switch career paths or go to a different part of the healthcare industry, such as I'm in insurance medicine. So I have that ability to say, I can choose when I go and work in the ER. But if you're in a remote community hospital and you're a custodial worker and that bed, that availability is dependent on you, and that hospital is very dependent on you for turning over that bed to get that next person admitted, but you yourself really can't afford to get sick, that's not kind of the healthcare system that we should try to create or maintain, right? We really need to almost turn it up on itself to do more. Anyhow, but I'll go more into that on the solutions, but that's how I feel health as well. One, monetarily, we could keep so much more in our pocket if we just walked a little more and knew what healthy options we had to ingest.
Mm-hmm. Wow, thank you, Dr. Ferguson. Such interesting points that you bring up there. Recognizing the privilege that many of us sit in, having that option, right? Flexibility to work remotely versus so many of those frontline workers, and even in banking, right? Our retail branches remained open throughout the pandemic. And so many employees who work those frontline jobs are more susceptible, right? To healthcare challenges, if you will. Also just wanted to note, the way we break down capital here at Zions Bank is in 3 ways. Human capital, our people; social capital, the trust and relationships that we build with the community and the people that we serve; and then the financial capital piece, the monetary investment. And just so kind of expanding the way that we think about wealth. I loved how many of you spoke to the people part of that equation. It's that support system, the social support system that we have in our community, right, when we're facing certain health crises. So does anyone feel inspired to respond to that piece of this conversation? The social elements and support system of people and organizations. Dr. Rodriguez?
So yes, I have to tell you that when COVID first hit, we were in a bad place because, as you guys know, nobody knew what to do, how to do, when to do it, and things were changing every day. But some of the things that I'm most proud of in our response is that we took and used the social capital and worked to actually develop more. And so we went, and as soon as we started testing for COVID, we learned that our patients that preferred a language other than English to speak to us had 5 times the rate of COVID positivity than those who had English as their preferred language. So that immediately set us into gear to start working on outreach and bringing the testing to them. And so they took and they refitted a wellness van and started bringing that closer to the communities that needed us the most. And then as time went on, we made other decisions that were based on equity. So for example, we have many properties at University of Utah Health where we could have had the vaccinations available. But the property that I work at, which is the Redwood Health Center, was a priority property because of its proximity to the patients that needed us the most. And we also made choices to benefit those patients. So in the beginning of the vaccine era, we thought that the best vaccine and the one with the highest protection rate was X vaccine. Maybe it was the Pfizer vaccine, maybe it was Moderna, but whatever vaccine it was, that's the vaccine that was put in proximity to our poorest patients. And that was on purpose to give the best to the people who need it the most. So those things developed more social capital for the institution, but they developed social capital for equity leaders like me, who saw us making decisions based on equity and not convenience, monetary stuff, or anything else. And that was wonderful.
Wow, that is so comforting to hear. Dr. Ferguson.
I would say that when it came to social capital, I kind of came in a little bit into my own, and what I've become even more passionate about, besides educating students and showing that students that are from an underrepresented minority group, that they become physicians, but also a big part of community education is trying to be a messenger of trust, because we know very well that the reason many in the Black community did not seek vaccination wasn't because of partisan rhetoric. It was because of a lack of trust. And sometimes not knowing who to trust, and knowing who that messenger was to trust the most. And someone said, I think that's you right now. I think you could probably have that role. So I was sought out, probably doing a presentation on the safety and the need to get a COVID vaccine, probably almost every 2 weeks, from probably April 2020, radio, wherever I could meet people that were not believers in vaccination or believers in masking. Let's go back far enough on how it was transmitted, or even just saying, yes, it is real, and yes, it is much worse than a cold. Trying to get that sense of priority to people was hard, but it built enough capital now that we have a COVID-19 page that people can go to, where they can have videos, something that I try to update regularly, especially when it came down to the Omicron variant. And then we have partnered with one of the community organizations that does a lot with Black immigrant and refugee organization, and that's GK Folks Foundation. And we actually did a series where I had Black pre-med and medical students paired up with me, and several of my Black physicians, where we did COVID and its intersections within the Black community, where intersection in the, for the economic impact, where there was an intersection if you need to travel. We did part where it focused on COVID and pregnancy. Those were COVID and cancer survivors. And then I think by them receiving information from people that looked like them and understanding like, all right, this seems credible. He took it, and he's telling us about a family member that took it. And other people are sharing stories about how their families members took it. All it takes, if I can reach one person on that webinar, even though I'm doing it every 2 weeks, that then spreads. It becomes like it's a good infection. And other 3 or 4 more people say, all right, I'll get that next shot. I'll get the next booster, because Dr. Ferguson said it was good. So, and then it became BPOU said it was good. And then it became more of, well, the Black Chamber said it was good. And then when Intermountain, the University of Utah, sponsors something with those other Black community leaders, then everyone says, all right, I think we all should get on board now and address our low vaccination numbers. So that's how I felt social capital was built.
Yeah, that domino effect. Such a beautiful articulation of that. Let's jump to Dr. Giffen, then Mikelle, and then Jake.
Sure. Along those same lines, Dr. Ferguson, and I really appreciate that, how you work the messaging and built the trust. And we have a similar type of colleague called a community health worker, which is embedded within the communities. And I see you all shaking your head. We have an actual service line department that's called Community Health and Wellbeing, that during the pandemic, we ran all the lists of anyone who's had any contact within St. Alphonsus over so many years, and then did that outreach by the community health workers to help them get to the mobile clinics, to our stationary vaccination sites, to help spread the message in the desired language about COVID vaccinations, where to go for care, and then did social needs screenings with those outreach, so that if they did need something else like food, transportation, connection to a primary care provider, that they were able to obtain that through that contact that's embedded within their community as well. So one of the ways that we help to make those connections and that social network.
My heart goes out to all the community health workers out there. Thank you so much for your commitment and contributions to this work, Mikelle.
Thank you. I'll just share a brief story. We have a partnership with Latinos in Action. I think a number of you do. It's a leadership embedded organization that is in multiple states across our country, focused on high school students becoming leaders in their communities and connecting to careers. And we sought out the opportunity to work with this organization in a pseudo community health worker type of relationship where students could become trained in aspects of healthcare that were recognized as needs in our community. So screening their family members for prediabetes or high blood pressure. That's evolved into a fairly robust relationship where over the course of the last couple of years, those same students have been educated on how to recognize signs and symptoms of COVID, when to get testing, when to seek medical treatment, when already testing positive. And now we're beginning to work through them to educate their communities around how to recognize signs and symptoms of stroke, because the disparities that exist in all of these health conditions are real, and we have an opportunity to develop the social capital in terms of trust with a relationship through Latinos in Action, but also develop the human capital, future healthcare workforce that can help us achieve greater diversity. So wanted to share that story with you.
Thank you so much, Mikelle. Such key work building those community partnerships and building the human and social capital right along with that. Jake.
I love all the examples that have been shared, and I wanted to add that it's often said that communities can heal themselves, that the expertise and the experience and the social capital within communities is vast and can be used. And I think through the pandemic, we also learned as a Pacific Islander Health Coalition to appreciate and to value the experiences and expertise of those outside of our communities as well. And through different collaborations, we're able to actually learn some great ideas and some other techniques that work in other ethnic or racial communities that we were able to adapt or to base some other things on. And very early on, you know, our community dynamics placed us squarely in the path of all possible risk factors for COVID with our multi-generational families and multi-family households, essential workers, underlying health conditions, and we were hit very hard. At the height of the pandemic, we had a team of 24 community health workers, CHWs mentioned before, who were doing all kinds of work from, you know, direct services, delivering groceries and PPE to folks who were homebound, to coordinating testing and vaccination. And the majority of those community health workers doing the work were not medical clinicians. They were not licensed providers. They were moms. They were college students. They were folks with other careers who just wanted to help, even high school students, like Mikelle mentioned. But they are experts in the communities. They're fluent in our languages. They're experienced in brokering our cultural dynamics. And in terms of human capital and social capital, I feel like they really are the unsung heroes in that work.
Wholeheartedly agree, Jake. And we cannot elevate community health workers enough, especially in the ethnic and racial communities where that language, again, is critical to building that trust. So thank you so much for all those contributions. I'm going to combine this next one into recovery and resources. So what does recovery look like, you know, coming out of the pandemic? We are still in recovery, so many of us, physically, mentally, and economically, and would love to invite all of you to share whatever resources, whether they be support services, policies, programs, investments that you or your organizations are making to help with these recovery efforts. So I'll just let anyone jump in.
I'd like to speak in
Jake,
praise of the Pacific Islander Health Coalition, and not at my own suggestion, but our very astute and observant leadership with our community health worker team, who realized that although everyone was doing really great work and staying very, very busy, that is rewarding in itself, but it also takes a toll. And there was a very intentional effort to set up circle calls and regular not focus groups, support groups for our community health workers and for those who were engaged in that work and often forgot their own health or deprioritized their own mental health and all of those other things that were happening because they were so engaged in the work. And so those groups continue, and we fully support working with and encouraging other groups to find providers who are usually busy and often don't have room for new patients, but we've been able to find creative ways to persuade them to come out and to actually provide direct services individually as well as for groups to make sure that folks are taking care of themselves and their mental health as well, so that they don't burn out, so that they can continue to do the great work that they're doing. And we can always improve, of course, but I think that's a great thing that all organizations can do to make sure that we're focusing on the mental health and the self-care of the folks who are doing the work.
Agreed. And I know none of us know what burnout feels like, right? That self-care component is so critical to our success. Dr. Giffen.
Yeah, I'm really glad that you mentioned that. I think behavioral health and access to behavioral health is so critical right now, especially as we continue to unpack the effect of the pandemic and its ongoing effect, where people did not seek preventative care. Chronic conditions were not cared for. We're still seeing the secondary effect from all of those who are still getting COVID, so it's not over. Still trying to help with vaccinations, and then just continued healthcare access. We have shortages in our healthcare industries right now that really makes it challenging to make sure that we can do all the great work that we're trying to do. So it's a combination of combining our community assets and our networking that we've all been doing in our organizations. I know St. Alphonsus continues to build with our community health workers and outreach there. How can we use different platforms, whether that's telehealth, whether that's mobile clinics, on-site primary care clinics? What are all the means that we need to do to make sure that we're reaching out to everyone and providing that equitably, because not all patients have the same considerations. So we have a global health clinic where we see our community members who've come from countries all over the world, and they have different considerations that we work with to help them get the health outcomes. And then just screening. We need to find out what are the demographics so that we can show that we are providing equitable health care. If we don't know demographics, we can't prove the outcomes. And so that's really important. And then social needs screening for everyone, anyone that we have who's coming into our health services is really important. But bringing healthcare to our community members is one of our big focuses this year as well.
So such important points. Any other thoughts on recovery and resources, Dr. Ferguson?
Well, as an organization that actually technically doesn't provide care, if anything, I'm a little bit of I would like to say that we're trying to direct and connect people to care, and often to providers where they feel they're more likely to receive less biased care, particularly from providers of color, or more of our larger, BPOU, I would almost say, provider network that we're building for the community. Because one of the biggest things is Utah's demographic is going to keep changing. Utah's going to keep browning. And one thing they often want to do, or they seek, is when they come into the state, is that I want a provider similar to the one I had from where I left, so be it Atlanta, Houston, Dallas, another major city. So I think what I try to do is make my website as robust as possible with resources and links that I can direct people there. And I try to use social media to pull them in, and repeated outreach to the community to tell them about, hey, here's a new health initiative. Here's a new health awareness campaign. You should be aware. Here are community grants that can help your small business. So I try to address through, I would say groundwork either not so much just health fairs, but going to as many community events to show folks that Black physicians do exist. We are trusted providers. I know trusted providers that you can seek care from, where you can get that testing, especially if you haven't seen a doctor in a while. There's more to address of your health right now besides getting vaccinated from COVID, because there's a lot that was neglected during the pandemic that I'm trying to school people about now. And it's like, yes, it is time for you to go in and get your mammogram. It is time for you to go and get that pap smear done. So I would say, if anything, we're trying to encourage and motivate the particular populations that have neglected or didn't do a great job in tending to their care before, because maybe they're too worried about trying to maintain their job, or they're too worried about, once again, trying to pay rent. So I am trying to do our best as Black physicians of Utah to motivate and encourage people to take better care of themselves. And I'd have to say that's what we're doing. So whenever I hear about a resource, we're letting people know about it immediately. I can't list a ton of links right now, but they are on our website.
Fantastic. Health Choice Utah.
Oh no, bpou.org.
Oh, bpou.org.
Yeah.
Okay, bpou.org.
You,
Awesome.
if you're part of, if you need Medicaid and
The
Medicare,
Resource Hub.
feel free to reach out to my daytime job when I'm wearing that hat. We try to address needs there as well, because we want people to seek as much. But if you don't qualify for Medicaid or Medicare, then I don't necessarily go to that website.
Got it. Fantastic. Thank you so much. Sounds like a hub of resources there. In the interest of time, just wanted to throw in one. We received a number of questions from our audience. Many of them have already been, addressed. But what I want to throw to the group is, what are your thoughts on insurance not covering integrative and holistic healthcare? We're treating systems instead of finding the root cause. Any thoughts there?
I could speak to that as someone that has to deal with this often. So holistic is often so if we're trying to say, as in providers all being connected or united, like a medical home, making sure that mental health is addressed, you have the family physician maybe at the head, or internal medicine provider, and then you make sure that if there is any home-based care, they're all united, laboratory care is all united, and that they're possibly on a schedule based on US-based preventative care guidelines. I feel that's a holistic approach, but also the provider who's at the leading this needs to make sure that they understand the person's transportation availability. Can they get to their appointment? Do they have the means to go and make a healthy meal? Are you directing them to a pantry because the person's too embarrassed to say, I can't go to the store and buy food? I think providers need to be asking some hard questions that sometimes make people feel uncomfortable, because they don't want to admit that they're poor or that they don't have access to something. But you are in that role right now where you're trusted. So I feel that would be like a really good step forward, is to try and encourage more providers to not tiptoe around those difficult questions in the room. That will improve the chance of holistic care if the docs are not scared to ask the question.
Great point. Dr. Rodriguez, and then Mikelle.
Actually, Mikelle is first.
Oh, Mikelle.
What a gentleman. Thank you. I love what Dr. Ferguson shared, and I would add that we're learning that, yes, in the primary care setting, we can be asking about social needs, connecting to resources, screening for intimate partner violence, and things that are really safe and important conversations to have between a healthcare provider and an individual who might be struggling. We're also discovering that employers can be advocating for some of these resources for their employees as well, and maybe in some cases have that trusting relationship. So an employer often is in a position to advocate for what's included in the plan they're offering to their employees. They also have a lot of employees who may not if they have lower income employees, may not choose healthcare coverage and are eligible for Medicaid, for CHIP, for SNAP, for housing benefits and other things. And creating a safe space to inform employees about those resources that already exist through public programs can be a great asset. And I'll just make a plug that with the public health emergency ending at some point, likely in the future, we have a number of people who are eligible for Medicaid or CHIP who may roll off those resources and are employed. So I think thinking about non-traditional ways to connect people to the resources that exist may be as beneficial as us thinking about it more holistically in healthcare.
Absolutely. Love that. Dr. Rodriguez. And then we'll have to close.
So I have to agree with what my colleagues have said so far on this issue. I think that there's an important piece that's worth repeating here, and that is healthcare systems, organizations, companies and industries. Their most important resource is their people. And we have to act like they are our most important resource. And so I really appreciate the question about, covering care in spaces that are more holistic and integrative health. I think all of those things are important. And when we look to how we're going to transform healthcare in the future, I think we need to work hard to understand that healthcare that is effective has to be based in science. And as we learn more about treatments that were once considered integrative or holistic or alternative, we need to integrate those into our medical practices and into our payer structures to make sure that our patients, our employees, our most important resources get what they need when they need it.
Love that so much. So in the interest of time, we are going to do a lightning round, 30 seconds. Final statements that you would like to share with our audience today. Take away from this conversation. Let's start with Mikelle.
We all have the ability to use our various forms of capital to improve health. And thank you to Zions Bank for thinking about it in those different contexts. Each of us have a role, whether we're part of the health system, or we're an employer, we're connected to the education system, or represent a nonprofit. We all can influence through our human capital, our influence in public policy, and the other assets we invest in communities to address health and wealth. So let's do it together.
Thank you so much, Mikelle. Amen to that. Jake.
Yeah, we have a Samoan saying "Ole fongava e tasi," which means you can only sit on the top side of the canoe, right? We're all on the same canoe sailing together, whether, like Mikelle mentioned, we're in commercial enterprise or academia, nonprofit, grassroots work, government agencies. We all have a vital role to play to make sure that our canoe reaches our destination of healthier communities, and that we can do that together.
Love that so much. We're all in canoes today with one another. Okay, Dr. Ferguson.
I would just say us as community leaders need to do more to influence legislative change at the local and of course federal level, because that's often controls the purse, right? And so, and it's not just marginalized groups that our health isn't doing well. We as a nation aren't faring all that well in regards to our health compared to our first world partners over in Europe or in parts of Asia. So we can all take steps to live better, longer, healthier lives. And some of that is going to have to be, do we do this at the price of, our capitalized sort of medical system? So hopefully we will continue to lobby for change and, bolster that ACA and improve the payer system, such as the system, because we don't sometimes like the restrictions we have. We want to pay more. We want to pay for more of that integrative healthcare. But if the purse is not funding that, we have to work around ways and using community resources to fill the gaps. Let's try to eliminate the gaps and just make the purse a little wider to address everyone's needs.
Such great points. Policy absolutely matters. Dr. Rodriguez.
So thank you for having us here. I would like to add that, you know, we are living in the strangest of times in a place where, for some reason, coming out of a pandemic, there are legislative and budget surpluses. And we have to figure out how to use those to benefit people in our communities and to benefit our communities as a whole. And maybe we need to think about things other than giving a 50-cent tax rebate and work on things like developing community infrastructure and safety nets. And then the last thing I'll say is get your flu shot. Get your flu shot. Get your COVID booster, please. We are still in this.
Yeah. Sometimes we forget that other viruses exist that are not COVID-19. Thank you for that advice. And Dr. Giffen.
Yeah, I too want to say thank you very much, Zions, and for all of the partners on this call. Very important. I echo all of your sentiments today. I think we need to continue to look for gaps in care and access, listen to the voice of the people, network together, and make sure that we're getting the word out for the things that impact health and equity in the most impactful way that we can. I just want to thank you all for using your health systems and your voice to move this forward.
Thank you so much, Dr. Giffen. I just want to thank each of our guests for taking the time to join our conversation today. I have been inspired. My cup has been filled because all of the wonderful insights that you've brought to the table today. One voice, one story, one conversation can make the difference. Building an inclusive and equitable healthcare system begins with us. It begins with me. It begins with Scott, Mikelle, Jake, Dr. Ferguson, Dr. Rodriguez, and Dr. Giffen. And it begins with you, all of you who chose to Zoom in today. We encourage everyone who tuned in today to take what they've learned, take what you've learned, and continue the conversation in your homes, in your schools, and in the communities that we serve. And this is how we will together set in motion a social and cultural shift that will lead to economic inclusion, health and well-being, prosperity, and growth. Thank you again for joining today. Please stay tuned for our next community speaker series in November. We will discuss solving for housing in the economic inclusion equation. Until then, we wish you a fantastic rest of your day, and we hope to cross paths with all of you again soon.
Thank you.
Thanks, everyone.
Thank you.